We're very fortunate to have an opportunity to bring Dr. Gibson. Dr. Chang noted that he was going to be giving a talk in California, so it was a great opportunity to invite him to our post-DDW symposium. Dr. Gibson is the Director of Luminal Gastroenterology Research at Monash University in Melbourne, Australia, and he will be discussing the why and how of applying the FODMAP diet in clinical practice. And for those of you who don't know, or if you do follow this literature, you know that his university is prominent in the field of diet and the impact on the gut. So thank you, Dr. Gibson. Thank you so much. Thank you.
Well, thank you very much for inviting me to speak here. It's a great pleasure to be at such a beautiful, beautiful venue and with such great weather. That's not working. That one's working, right. That's not working, yeah, okay. Okay, so what I'm going to cover is about diet and IBS in general, a bit about the FODMAP concept, how to implement the diet, the issues in its implementation and where it fits into treatment algorithms. So, why should we use diet in IBS? And this is something which I think is something which patients have been demanding for many years, because they know, and we know from a lot of data, that ingestion of food triggers symptoms in more than 60% of patients, and that's been well documented on multiple occasions. You would all be aware that there's a huge community as well as patient interest in using diet to treat illness and also using diet just to be healthier. Patients already use diet to influence their symptoms because it's the primary behavioural factor that they use, and it sort of gives them some sort of feeling of self-empowerment. We also know that there are multiple mechanisms by which food can induce symptoms, and only some of those have currently been explored therapeutically. So there may be lots of things happening in the future. But what has really changed the scene is that we now have randomised controlled trial evidence of efficacy of dietary change in IBS. And the probably even more important is if we don't engage as gastroenterologists, the naturopath, Dr. Google and the person who lives next door will, because they're the ones who give the most dietary advice. Now, the common dietary strategies used in the United States are gluten-free diet, low FODMAP diet, and exclusion diets based upon some immunological testing. These were all examined by the American College of Gastroenterology not long ago, and they concluded that there was no evidence for gluten-free diet. In fact, only one randomised controlled trial, which was basically negative. And for exclusion diets, the evidence was very poor. And they actually suggested that low FODMAP diet was the way to go. The recommendations were weak, quality of evidence very low, and this is because these are dietary studies. They're using grade criteria which are based upon criteria used for drug trials. And if any of you have ever been involved with any dietary studies, you will be aware that it's extraordinarily difficult to get the same numbers, the same quality of placebo, and so on. Now, the FODMAP concept generated not because we had discovered these wonderful sugars that no one else knew about, but because we just put a few things together. There was a lot of information about, around the time that we were interested in this, there was a lot of fervour about fructose causing gastrointestinal symptoms and low fructose diets. There were a few publications on that. However, it never really gathered any momentum and didn't really penetrate therapies. The low lactose diet in people who have got hypolactasia has been around for a long time, but there are sufficient studies now to be convincing that a lactose or a low lactose or a lactose-free diet do not really impact symptoms in IBS overall. Fructans, which are fructooligosaccharides, have been known to induce symptoms of IBS
although had not been implicated therapeutically, whereas galacto-oligosaccharides are those things in legumes and what we call windy foods, which are gassy foods, that they've always been on lists from the American Gastroenterology Association and so on of what to avoid to reduce wind or gas. And polyols, sorbitol and mannitol, we all know that they induce gastrointestinal problems because it's on packets of chewing gum that are sweetened with sorbitol, but these things are in foods as well. And so the idea was that all of these things will induce symptoms identical to those in IBS. They all may act in the same way because they will distend the abdomen because they're small molecules, they're poorly absorbed and or non-digested, and they are fermentable, so that they will produce things to distend the abdomen. And I can show you this from it's always nice to have a visual representation of this, and this is from an MRI study from Robin Spiller's group in Nottingham, and you can see in the white, that's all small intestine, and that's the water in the small intestine after a dose of, on the left is glucose and an equivalent dose on the right of fructose. Fructose is slowly absorbed, so it maintains this osmotic load in the small bowel, and you get at least 20% more water according to our ileostomy studies. The other thing that we found when we were first experimenting with this, we put people on what was a high-ish FODMAP diet or a low FODMAP diet. This was healthy controls as well as patients with IBS. You can see here that you've got on the y-axis is the hydrogen production, which is telling us about fermentation in the colon, because hydrogen only comes from the colon. And you can see that with a low FODMAP diet, there was very little fermentation. But what was really surprising to us, and probably because we were naive at the time, was that the hydrogen production from being on 3 meals a day of high FODMAP diet was constant over the whole day. It was going all the time. It wasn't just a little bit of hydrogen after each meal. So what you were getting was then this distension of the bowel, which we believe, which of course we know is the way that we sense things and the things that cause bloating and other problems. And so the whole FODMAP concept was we took 1 + 1 + 1 + 1 + 1 equals 5. If we stop them all, we will get much more benefit, and we will find out whether these are important. Now, this all happened, all of these things I've been talking about happened in all of us. This is normal physiology. What is abnormal in the IBS patients is what their gut and what the gut's nervous system and the gut-brain axis is as response to this distension. So the idea is that if visceral sensitivity is present, then hypersensitivity is present, then you will get symptoms. Now the term FODMAP was it's one of the few acronyms that actually is meaningful, as opposed to all the drug trial acronyms which come from very funny parts of the words. And these are the oligosaccharides, disaccharides, monosaccharides and polyols. They're all fermentable and they're all slowly absorbed or non-digestible. And they're present in many foods. They're not present in meat, but they're certainly present in fruit and vegetables and cereals and dairy products. Now, they're present in differing amounts, which was really important, so that there are high and low levels of them. But there's lots around, and it's not easy for patients to recognise where they are. Now, when we started all this, we had great difficulty knowing where fructans and galacto-oligosaccharides and polyols were, because there were very few studies on their content in food. And so we've been, for the last more than 10 years, have been measuring foods and getting a database of information about where these are. And you can see here the examples. If you look at the breads, the rye bread has lots and lots of particularly fructans. Spelt bread, which is from an ancient wheat, has much lower fructan content and has low levels. Gluten-free bread has low levels. And this just reminds me to say that one of the early discoveries that we had, which was known by the agricultural industry but not by the medical side, certainly not by us, that gluten and fructans particularly coexist. And that if you have a cereal which is gluten-free, it almost certainly has very low levels of very low levels of fructan, whereas if it's a gluten-containing cereal, they have fructans, usually plenty of them. And so the idea is that people who say wheat causes bloating and I go gluten-free and I feel better, it's because the gluten was stopped, is probably wrong. And there's a lot of evidence now to say that it's actually the fructans that's reduced and it's not the gluten. So it's attribution of things that is important. Now, the other problem we had then, because this is not a FODMAP-free diet, it's a low FODMAP diet, we want to reduce the FODMAP, so we have to know whether they're low or high and had to have a cut-off levels. And the cut-off levels were determined by a series of studies about what was inducing symptoms with different amounts, and so cut-off levels have been created. And it's almost arbitrary, but it's based upon lots of observational things. Now, the problem we had then was, how do we get this information to people? We tried publishing, and if you've ever done any food composition studies and tried to publish in the literature, forget it. Journals are not interested in publishing that sort of thing. So what we did, we actually hooked it onto a little clinical study to try to get it there, but it really wasn't very good because our database was increasing all the time. You can publish it on the internet, but what happens is that people produce lists which are based upon a current list, but that current list never gets changed. The list they have never gets changed. So the internet is not a good site for it. So Jane Muir, who co-runs our group, she had the brilliant idea of putting it into an app because people needed to know this information when they were buying food, when they were purchasing food, when they were going to restaurants and so on. So this is the origin of the Monash University FODMAP diet app. And it has our whole database of food composition, which is the only one that is available in the world, and that the foods are classified according to a traffic light system, red being high, amber being medium, and green being low. And it also tells you what FODMAPs are in there because different people have different sensitivity to FODMAPs. It's in Spanish, it's in English, and it's got many other things associated with it. Now, the important thing is that it does have a cost, but all the money that Monash get, that Apple and Google and people don't take from us, goes back into this program. And this is the only way we've been able to do our research and keep our laboratories and our apps going, because it's very hard to get good funding for dietary research. So how do you then implement this dietary program? Well, the diet has evolved into a dynamic process. There's 3 phases, and anyone who's been involved with exclusion diet methodology, this is standard methodology for it. What you do is you start off for the phase 1 and you would avoid all foods that are high in FODMAPs and replace them with foods that are low in FODMAPs in each of the groups. So you don't actually take any food groups away. You would do this for 4 to 6 weeks was what we used to say. It could be 2 weeks. We used to say 4 to 6 because that's when we could get an appointment to see them next. And if they were compliant and there was no benefit, which we would see in about 1 in every 4 people, they've got to stop the diet. And as you know, and as has been talked about today already, that people who have IBS, who are on diets, accumulate them, never stop them, even though it doesn't work. You know, you've been on gluten-free diet for 3 years. Did it ever help you?
No. So why are you still on it? Because I'm too frightened to go back onto gluten. So this is what we call the bleeding obvious, but it's something which has to be stressed because you don't want to stop your FODMAPs if you don't reduce your FODMAPs if you don't have to. So if there is benefit, if there's lots of symptomatic benefit, then patients go through a phase of a step down according to tolerance, and then onto a personalised long-term diet. So, and the app helps a lot here in managing all of this. The other thing that happens is that it's all the data, just about all the data in the publications are dietitian delivered and are not delivered by a piece of paper given to the patient to go away and learn how to do the diet. So the phase 1 really is our test of are FODMAPs important in this person. So it's almost a clinical, a trial of therapy, and the patient starts to learn where these FODMAPs are. And it's not meant to be a long-term therapy, and we don't really want people to be strictly low FODMAP long-term, and we would use other therapies if they couldn't reintroduce. Now this phase is where all the randomised controlled trials have been done, because you can do it in acutely, but it's very hard to do long-term studies. The important studies are all shown here. I think the first one, they've all used different comparators. This one was our feeding study where we fed 30 patients with IBS and a few healthy and a few Crohn's disease patients for 3 weeks on one diet, which was a standard Australian diet, and 3 weeks on a low FODMAP diet, and then crossed over to the other after a appropriate period of washout. And this was the study which really proved the concept that lowering FODMAPs improves symptoms. Following that, we've seen a Canadian study where it's been compared with a high FODMAP diet. We've seen a study from London looking at versus a habitual diet study, the study from Shanti Eswaran and Bill Shea's group versus a modified NICE diet. That's the English diet, which is more about style of eating than about choice of food. And then a very important diet from Heidi Stardaker, who from King's College, who actually designed a placebo diet, which is quite an achievement, and it was a very successful study because not only did she achieve a placebo diet that didn't, and patients didn't recognise it, but also showed that the low FODMAP diet was better than the placebo diet. And I mentioned her name because Heidi, even though she did this in London, we're very proud of the fact that she came from our group. So if you look at the meta-analyses, you can do meta-analyses of these, and I don't really like these meta-analyses because it's a single therapy versus a different comparators. But it does show you that there's some very nicely that the diamond is the right side of the of zero. There is one study that didn't show any difference, but if you look at that study, there wasn't very much difference in the FODMAP intake in the patients on the low FODMAP diet. Okay, what about this re-challenge, the second phase? Very important, because what we're really trying to do is identify individual sensitivities and how much people can tolerate. Because we've recognised for a long time that some people, fructose is not a problem. Some people, galacto-oligosaccharides is not a problem. Some people, fructose is a big problem to them, whereas the others aren't quite as big. And I'm sure this relates to their microbiota and various other factors. And the reason for re-challenging is for all the obvious reasons. You want to restrict the less restriction, the better. And the process we use, and there's a few different ways have been published and discussed, is that we challenge one food at a time that's got one FODMAP in it. Like if you wanted to challenge with honey, with fructose, it'd be honey or mangoes, and then with honey you do a teaspoon first day, 2 teaspoons next day, 3 teaspoons of ecstasy. If they don't get any symptoms, well, then it's not really an issue. And with onions, because onions are high in fructans and onions are considered generally public enemy number 1 in the IBS area, that we start with 1 onion ring and build up from there. And at the end of it, what happens is you're staying low FODMAP the whole time through this, and then after a few weeks of doing this, people know what they can and can't tolerate and what they can tolerate a bit. And then it's a matter of getting then into the personalised FODMAP diet where they only restrict according to their specific FODMAP problems. Now, the reason why this diet is, we don't like calling it a diet because when we used to treat people with a low FODMAP diet, we would see them 2 years later and say, "How are your symptoms?" "Oh, really good, well controlled. Are you still on that diet?" And they said, "Oh no, doctor, I've stopped that a long time ago. Not on that diet at all." And I would just say to them, "Well, so you're eating onions now?" He said, "Oh no, never touch onions, never touch onions." "What about apple?" "Oh no, I can't stand apple, because it gives me the symptoms." And what was happening was that people were still on they were just making sensible food choices based upon FODMAP content and on their experience. So that's the idea, that you don't want people to think they're on a diet, but they're making sensible food choices, just like we all make them according to taste, to texture of food, or all sorts of things like that. What this means is that patients are empowered, and this is the most important thing. You want them empowered. Now, they're also empowered to increase or decrease the restriction they have according to whether they're having a bad time or a good time with their IBS. The second thing is that we see the very severe patients who get a lot of pain and who go into the A&E department because of severe pain. A&E do not like these patients in their department. Now they don't go in there, our patients, because if they have a bad day, they'll know why they've had a bad day, because they shouldn't have had that meal that their mother said didn't have any onions in it, etc., but she probably put them in because she thought it would spoil the meal. And so they are happier. So this is another part of empowerment and reducing the pressure on you. Now, does the personalised phase work? Is it good? And you can't do randomised controlled trials in this. So there are 6 prospective studies with 3 to 18-month follow-up after they've gone through the reintroduction. And more than 75% of patients in the studies have been able to reintroduce. Overall sustained symptom response has been reported as 57 to 82%, and there's been no evidence of harm from the studies. Okay, so now what we would like to do is not treat people who are not going to respond to the diet. So we want to know what predictors we've got. And there's been a rumour around, and people talk about this, I hear it talked about all the time, that the diet only works in IBS diarrhoea, predominant type, which is completely against all the literature, all the publications. There have been some studies only in IBSD, but it works in all bowel forms. Breath hydrogen tests are being done. There's money to be made doing breath hydrogen tests after fructose, after polyols, and if you malabsorb fructose on this artificial situation where you take a large amount of liquid fructose, it doesn't predict whether you're going to respond to the diet or not, because a lot of the symptoms are unrelated to what dribbles over into the colon to be fermented, because most people will absorb all of their fructose. So they're not predictive. The only predictive things which so far have come out have been about the microbiota, the different patterns people have may predict. And I'll just show you a couple of things. One is that can you just get a fecal sample,
do a simple test of the microbiota composition and say you are going to respond, or you will, well, more importantly, you will not respond, so we're not going to bother with you in doing it. And this is a test from, this is one which was using the GA test, which is gives a dysbiosis index, and it's a bit of a bizarre test because it's comparing your DNA, your bacterial DNA against 100 Norwegian people who apparently are normal. And I just hope that Australia beat Norway in the World Cup, Women's World Cup today. What they show was that yes, there is differences. It's been shown by Bruno Ciamptazzi from Texas as well, and other groups, that people who respond do have a different pattern of microbiota, but there's a big overlap. And you can see here just from these data that in the open circles, yes, there is some separation when you do these PCA analysis, principal component analyses, but it's not enough to say it can separate who should have the diet and who shouldn't have the diet. One of the things that was really very exciting, I think, is the fact that you might be able to sniff the poo and be able to tell. Now we're not proposing the gastroenterologist, instead of doing a colonoscopy, just get the patient and lift their have a sniff. Dogs can, that you're probably all aware that dogs can diagnose bowel cancer by smelling people's faeces. And this has been now converted by doing chromatographic analyses where you get lots of peaks, doesn't matter what the peaks are, of all these volatile organic compounds. And then if you do some analysis and get algorithms together, you might be able to separate the groups. And this was work done from Heidi Staudacher's study retrospectively of faeces, and they were able to completely, with 100% certainty, separate the responders from the non-responders. However, we have no prospective, and this algorithm may not work in the next group of patients that you look at. So this is a really exciting area because doing this test is easy and it's not terribly expensive. Okay, now if I was talking to you about a new drug, we want to know what the risks are, what the problems, and often with complementary medicines and with diet, these are not discussed enough. But it is really important. I think Lin Chang has raised issues about this in her discussion earlier. The first thing we worry about is that restrictive diets are going to psychosocially restrict people. And no one's going to invite them to dinner because they don't know what to give them, this sort of thing. And the psychiatric condition of ARFID, which Lynn talked about, is a real issue in our IBS patients. And we also have this other term which came from that wonderful journal, the Journal of Yoga, orthorexia nervosa, of the obsession with healthy eating, the people who only eat gluten-free, organic, and then vegan altogether. And this is the sort of problem that we don't want to exacerbate by putting people on restrictive diets, and we don't want to precipitate it. In fact, there is the key thing from the presentation from Lynn today, from the study from Bill Shea's group, is that gastroenterologists, when they're referring patients for dietary management, for dietary restriction, none of them had actually identified that there was a problem in people who had ARFID. So this is where the awareness of this is really important. So the diet could lead to nutritional issues, and calcium and fibre seem to be at most risk, but in the longer term, these risks seem to disappear and the fibre and the calcium come back to normal. And food-related quality of life, there's the only studies done in this that showed that there was an increased cost. Patients claimed there was an increased cost to using the personalised FODMAP diet, and they had difficulty eating with family and friends, or travelling. The other thing that there's been a lot of noise about is that we're poisoning the microbiome, we're creating dysbiosis, and that we're going to create all sorts of diseases with this. And in fact, it's not. There's no basis for it. There's a lot of studies now showing that diversity is not affected. That's the major endpoint which we believe is associated with illness. There are, of course, because FODMAPs are food for bacteria, there are effects on bacterial communities, particularly in the ones that produce lots of short-chain fatty acids. But these are all reversed with personalised diet, and which has been now shown. I don't have time to show you all the data. Okay, so it's great having a therapy, but can we implement it? There are difficulties with implementation. The first thing, are gastroenterologists interested in using diet in these patients? And of course, if they're not, it's not really going to go anywhere. Well, the first thing we need is evidence for guidelines to have it in, and the ACG guidelines now have it there. Bill Shea did a study of, some of you may have been involved, a questionnaire study. There were 1,562 gastroenterologists across America, and 50% of them, more than 50% of them, recommended dietary therapy to more than 3 out of 4 patients with IBS. So there is a big interest and a use of diet. However, when you look, there was only 21% of those doctors referred patients to dietitians, and less than 1 in 3 of those were GI dietitians. And here, this just shows you the sometimes, rarely, almost never using a dietitian. And this sort of suggests that the doctors either think they're really good at the diet or they're not really implementing it well, because our medical model is not very good at giving the time to do this, and our training is not great. So I've been pushing dietitians very heavily, but do we really need the dietitians to deliver the diet? Well, why are they of advantage? Well, most evidence comes from this setting. That's the first thing. The second thing is maintaining nutritional adequacy is the dietitian's #1 priority, and so this is really important to educate about how to replace, because it's a replacement diet, not a exclusion diet. The reintroduction phase is really important to reduce the impact of the diet on quality of life and gut microbiota and all the rest, as I discussed, and that is much better implemented by diet. They can do it when they're jet lagged, whereas we as gastroenterologists would have to practice a heck of a lot to do this effectively. They are wary of risks of disordered eating and need of psychological input. They know about ARFID, they know about orthorexia, they know about anorexia nervosa. This is what their training is. And we've already seen from Bill Shea's data that gastroenterologists are not particularly good at recognising these issues. And dietitians can deal with the practical issues of being on a diet, how to read food labels, meal planning and recipes, which I would guarantee there wouldn't be too many people here confident in guiding their patients. But of course, the dietitian needs to be adequately trained and equipped, and it's not something that the GI dietitian who's trained in this area will be able to do all this very efficiently. Now, is there any evidence for this? Well, there was a poster at DDW from Carolyn Tuck, who was a dietitian who did her doctorate studies with us and has been in Canada. And she when she first got to Kingston, she looked at 80 consecutive patients referred to their gastroenterology clinic, and all of them had previously been recommended to trial the FODMAP diet by various people, and she retrospectively interviewed them and did a food frequency questionnaire to measure what they were eating. And these are the results, and 24 of them had seen a dietitian and 56 hadn't. And she was somewhat disappointed that the people who claimed, this was retrospective, fairly low quality way of assessing, but there was no significant difference between the success of the diet, the apparent success, 67% versus 50%, which wasn't significant. However, the important thing is that the actual quality of the implementation was extraordinarily different between a dietitian and a no dietitian.
And you can see there that the appropriate implementation, particularly get to phase 2 and phase 3, was abysmally low in people who were not doing it under a dietitian's guidance. What about just sending people to Dr. Google? Is this a good way of doing it? And this is how many people would do it. You would give them a piece of paper and they would then go to Dr. Google for more information. And this was of interest to Bruno Ciampanzasi, a paediatric gastroenterologist in Texas. He looked at the food lists on the internet that are available. There are lots of food lists available, and they were just like chalk and cheese. They were discordant completely. There were lists that were made in the early days when we hadn't got good food analysis, and there are some people who clearly can write lists but can't actually transcribe. So they're very inaccurate. The second thing he looked at was then, in a subsequent study, looked at the readability and quality of advice about IBS on the internet, and using this discern instrument, it should be near 4, the quality, and the quality was poor. He also looked at what dietary advice the internet sites were giving, and it was everything and anything. The FODMAP diet was in there, about 50%, but there were lots and lots of things being advised. So if you send your patient to Dr. Google, how are they going to work out what they should be doing when you get that sort of information? So can we teach it without a dietitian? Well, the reality is that FODMAP-trained dietitians, of course, are not readily available or funded in current systems in many parts of the world, including the United States. There is some funding, but it's not always available. Many patients, of course, successfully learn their diet without a dietitian, but the problem is that the paper-plane method of teaching a diet doesn't work. The paper-plane method is that you get a piece of paper with the diet on a food list, you get it into a paper plane, then you throw it to the patient catches it, and then has to go and work out what to do. And I think this has been shown in other areas to be a very poor way of delivering a diet. So what can we do? Well, the doctor can be upskilled, and where we've been working with in our own group as well as with people in the United States about developing a toolkit. You could utilise nurse practitioners and physician assistants to learn about this, and they've got the time, and this is a very good thing that can be done. We've done it with nurses to learn how to deliver the diet, and although you've got to select your patients well. But of course it's best to engage with or employ a skilled dietitian, and I say this because your patients will have an improved quality of life because of engaging this person, but more importantly, the doctors, you will have an improved quality of life because patients will be happy. Now, the dietitian's toolkit we have developed, and this is our Monash toolkit. We've got things like the app, we've got a website, we've got online training courses which are excellent, and booklets. And I just refer you to, we have a stand out in the display. Alan Greensmith is there, very happy to talk to you, and I'll be there at lunchtime. And some of our tools are there. So what we're trying to do is work out how we can make a gastroenterologist toolkit, and we don't think that gastroenterologists will sit to 30 hours of an online course to learn about the low FODMAP diet. So that's all being worked on. Okay, so we've got a diet. Where does it fit into your management? Where should it fit into the treatment algorithms? Well, I'd like to give you my personal view on how we manage IBS. We make a confident diagnosis and transmit it to the patient. It can't be hedging. They have to have a confident diagnosis, and we harness a placebo, which is the biggest tool we have, the best tool for any chronic illness. And then in some people, we would want to institute specific therapies. And to me, there are 3 specific therapies. There are dietary therapies, psychological therapies, and adjunct therapies, adjunct to those other ones. And the adjunct therapies, that's where drugs come in, where manipulating the microbiota, physiotherapy, biofeedback techniques, which are fantastic, and some neuromodulatory techniques, which are coming. So why do I say that these are the 2 primary things that we should be doing? Well,
They're well-defined strategies. They're not woolly. It's not the psychological therapy are not just talking to people and counselling. It's more, they're specific. If you've got a chronic non-fatal illness, managing your lifestyle and psychological issues with a prolonged benefit is a lot more attractive than taking non-curative drugs that only work as long as you take them. Efficacy seems to be present for all symptoms in 3 out of 4 patients with all of these techniques, and these are self-empowering, which is really important for patient satisfaction. Now, you might think, well, what are the psychotherapeutic? There's not much. There are lots of them, and including cognitive behaviour therapy, mindfulness, gut-directed hypnotherapy. Now, if you look at the meta-analysis done by Alex Ford about 5 years ago, published 5 years ago, so it's pretty old now, you can see that there are lots and lots of studies in CBT, relaxation techniques, and gut-directed hypnotherapy, and you can see that they all fit on the right side of the single line, or all favour the therapies. But you will also see here that the gut-directed hypnotherapy and cognitive behaviour therapy seem to work better than simple relaxation techniques. But there are also several studies in IBS using online or self-taught techniques, although they don't seem to work quite as well as a one-to-one. So we wanted to know where these fit in. How do they compare to a low FODMAP diet? So we did a randomised controlled trial where we randomised people to a standard FODMAP diet, which with a dietitian, teaching them at 1 week, 6 weeks, only saw them twice. Hypnotherapy, gut-directed hypnotherapy, the Manchester Peter Waldwell process, which was once 1 hour 6 times over the first 6 weeks, and then we saw them at 6 months again, and people improved similarly with the low FODMAP diet and the hypnotherapy, and they were really good at 6 months. And it was about approximately 72% of each group were maintained their responded and maintained it. Although the combination done at the same time didn't really give anything. There's been a more recent study using a yoga technique, a serious yoga technique, where it seemed to work just as well as the FODMAP diet. So what these are showing, and the patients in both of these studies were not the serious heartache patients that you have in your tertiary referral clinics, but are people who are relatively undertreated from a general practice type setting. So when applied as a primary therapy, they seem to be as effective as a FODMAP diet in the short and longer term. These things are not rescue therapies when you're in trouble. They can be, but they probably should be frontline therapy. And we assume CBT would work equivalently as well. So how do we make the choice of therapy? Well, I think obviously the availability of expertise is important. If you don't have a hypnotherapist, you can't do hypnotherapy. And you've got to have patient buy-in, and we'd have no trouble in getting people to have hypnotherapy. Some people don't want their head mucked around with, but in fact we're trying to use the hypnotherapy to influence their gut, is the idea. Some people don't want to do diet. If we then, of course, some people are not suitable for one therapy or another. You don't do hypnotherapy in a psychotic person, and if someone has got anorexia nervosa or has got serious ARFID, you probably want to think of a different therapy than diet. What about the cost? Are they cost effective? Well, there was no data until DDW when Eric Shah presented this poster in people with IBS-D based upon published data. He did this study with Bill Shea's group and our group. And here on the y-axis is the cost, the x-axis is the effectiveness, the quality gained. And from a payer perspective, you can see that tricyclic antidepressants were probably the cheapest and work reasonably. But this is only over 12 months, mind you. But you can see CBT and low FODMAP diet were the clear winners in not a high cost, a low cost, and the most effective of all these groups. And from a patient perspective, very, very similar data are there. And we just hope that this is peer-reviewed and published soon, as it might start influencing payers to fund their dietitians. So my take-home messages are that this diet, this FODMAP diet, we don't call it low FODMAP diet anymore, we call it the FODMAP strategy or FODMAP diet, has matured into a dynamic process of reintroduction, personalisation phases and with maintenance of efficacy. It's efficacious for IBS and does have evidence base. It's best delivered by dietitians. Guidelines support its use. It should probably be applied early in management, that's our belief, and that it's cost effective for the payer and the patient, at least for IBS-D, and we're waiting for the data on the other sorts of IBS. And personalised therapy is the rule, because we've got to consider the likely risks versus benefits. Now, I'd like to indulge just with one more slide here about the evolution of therapy in IBS, because I think it's got important messages. First, when I trained, which was a long time ago, I was taught how to get people out of the clinic, not how to manage the patient, how to help the patient. And we used placebo, we used drugs. Diet was something we sent to the dietitian to say increase the fibre, decrease the fibre. The patient had come back unhappy, and the dietitian was even unhappier because they didn't know what to do with these patients and they really didn't win with them. We used psychology and psychiatry as rescues, and the ownership of IBS was with the neurogastroenterologists, the people who do the motility and done all the work in understanding IBS. What happened now is that we still use placebo, but for us, in our group, and in many places or in some places in the world, diet and psychological therapy become the frontline therapies, and we use these other things for adjunctive therapies. And we still use psychology and psychiatry to rescue patients in dire straits. But the most important message here is that the ownership of IBS now is multidisciplinary. The neurogastroenterologist is still their domain, but it's general gastroenterologists, it's dietitians, it's psychologists, it's nurses, it's physiotherapists, and probably it's patients who now are much more empowered. So that I think that this evolution has been a really important thing, and it's made IBS gone from being a heartache, a heart-sink thing when a patient with IBS comes into your surgery to something which is very, very easily managed because you know you're going to be able to help considerably those people. Thanks very much.